Good evening, everyone. Welcome to First Aid AMC Clinical, free 2-week sessions. Now, we already had one trial class on psychiatry mental status examination a few weeks back. I hope most of you have joined that session. If not, then definitely you can go through our recording. The recording has been already given to First Aid AMC Clinical Facebook group, and also you can get it in YouTube. So I'm certain that all of you know what is First Aid AMC Clinical. We don't need to say that. So First Aid AMC Clinical, we have been preparing the IMGs and international doctors for more than 7 to 8 years right now. So it's not something new. We know what we are doing. We know that what questions are important, what should be your approach for passing this exam in your first attempt. And it's not just by saying, but you can definitely have a look in our Facebook group that how much students are passing from this course every month. We are proud to say always that our course has got the highest number of passing candidates in AMC Clinical. And most of them are first time to attend candidates. And if you know about AMC Clinical, you know that is very, very hard to do. But still our candidates with proper guidelines, materials and everything, they are able to do it. Just, I think yesterday I've got a message from 3 doctors who just passed their February exam and many more to come. So you know that if you prepare this exam in a concise and in a smart way, you can definitely pass this. But the problem happens is that a lot of candidates, they waste a lot of time to even know how to prepare for AMC Clinical. And they go around and around, they try to find out the right course for them. And on the way to do that, they become more and more confused. That's why we offer you these free 2-week sessions so that you don't need to do that. You can join these sessions and decide that if you are liking how we are teaching. And if you're liking our style of mentorship, if you like what we're doing, that's the main purpose of this 2-week session. I know that there is not a single course in Australia or anywhere in online who offered 2 weeks free sessions to their students, but we do it. It's just because that I said in our trial class that anyone can take a single class, which will be fantastic, like amazing. Anyone can do that. But if someone can take 2-week session and you like it really, that's the time you will be sure that yes, this is the right course for me. And that's why I advise all of you before you join the sessions, make sure you join this 2 weeks course and 2 weeks free classes, and then you decide. And I know that already a lot of you, or I'm sure most of you, are already part of the course. I can see already in our course group, there is a lot of students who has already enrolled. So I'm sure that you know about this course. We don't do a lot of advertisement. We don't do anything. This course runs twice in a year, and candidates like you or any other doctors, they just come from people's world. Okay, so the candidates who join this course, they usually know about us just from their colleagues, friends, or anyone who has already done this course. So you can also look at our Facebook group and you can read all the feedbacks that our past students has written. And I'm sure you will know the value of this course. Okay, so a lot of talking. Let's start the session. So at the end of the session tonight, I will again discuss what this course is all about and what we are going to finish in this course and everything. But we'll now start with our role play session. The session that we normally take, it is similar like this. We first take a theory class, and once we finish that theory session, we do a role play on that. Now, don't think that psychiatry is over. We just took one class, and in the course, you will get 3 or 4 psychiatry classes. So it's not finished. but mental status examination is the backbone of psychiatry. So that's why we try to do role play on these cases, because many of you, or even most of you, will get a case from this topic. Okay, so that's why it is super important for your exam. Today we are not going to do theory. Theory has been already covered, but we are going to do some role play on those topics that we have discussed. And you are going to have an idea that how you should do role play with your study partner. Because part of your preparation will depend on your way of role play and getting a study partner who you can do role play and getting some feedback from them and improve yourself in that way. So today we are going to show you how to do a proper role play, and also many of you might be in the middle of your preparation, and I would be happy to role play with you to give you some good feedback. So who wants to do role play first? Dr. Shanika? Okay. So let me unmute you. Dr. Shanika, can you hear me?
Hello, I can hear you, sir. Can you hear me?
Okay. I can hear you well. Thank you, Dr. Shanika. Okay, I'm just going to give you a case. I'll share my screen just in a moment. So this is your case. So you'll get 1 minute 30 seconds to think about the case, and then you will get 7 minute 30 seconds to do the case. Okay? But in exam, you get 2 minutes to read the case and 8 minutes to perform the case. Okay, your 1 minute 30 seconds started.
Mhm.
All right, doctor. So this is your patient, Sarah. You can start.
Hello, I am Dr. Shanika, one of the doctor in the department today. It's very nice to meet you, Sarah. I am there to help you today. Are you comfortable with me to have a discussion now? And please make sure that what we are talking today will be very much confidential, and if there's unless there's a risk to you or the others. So don't be hesitate to talk with me, and I will be there to help you. So from the notes, I got to know that you are trying to hang yourself with a rope. So I'm very sad to hear that. So could you please tell me more what actually was happening? Yes, Sarah. Is it okay? Are you comfortable to talk with you now? Uh, can you please tell me more?
I I just don't want to leave. So
Oh, I'm
I
sorry.
don't think like I should live anymore. I don't deserve this life.
Do you still feel that your life is not worth living?
Yes, I know that. I just don't deserve.
Okay. Okay, I'm so sorry to hear that. Could you please tell me why do you think so? Do you have any, how long do you feel like this?
Since I killed that cat, and it's just been 3 weeks that happened.
Oh, do you think still that incident was happened because of you? Do you have any guilt about that?
Yes, I am guilty. I know, and everyone knows that. I
Okay.
killed that cat. I couldn't save that cat, and it was my fault.
Okay. Do you have any history of previous attempt of suicide in the past?
No,
Mhm. Okay, that's good. Sarah, I will ask you some screening questions. Don't be stressed. That may feel strange to you, but is it okay with you? Do you,
yeah,
sorry, do you feel or hear or see anything that other people don't?
I don't know what that means. I can't feel anything, but yeah, I can't see also. I think it's okay.
Okay.
But I but sometimes I can hear people are saying that I am the murderer, and I know that because I have killed that cat.
Uh,
Yes, I think I hears that someone is saying all the time in my ear, I'm the murderer.
do you physically see them, those who are talking about you?
No, I can't see them. It feels like they're maybe at some other room.
Okay. Um, do you feel others are spying on you, or they are
No,
trying to harm you? No.
no,
Uh, do you think someone is controlling you?
no.
Do you think others are talking about yourself? Do you think?
Yeah, everyone in the street talk about me. Everyone in the clinic talks about me. Yeah, it's just like constant talking about my behind. When I go there in front of them, they don't say anything, but I know they're talking about me.
Okay, okay. Um, do you feel that you need some medical help?
No, I just need it to be end. I just want to vanish.
Okay, I'm really sorry to hear that. What will you do if this room catches fire at the moment?
I'll just stay.
Or uh, can you please tell me where are you at the moment?
Yeah, in the hospital.
Okay. Do you know who I am?
Doctor,
Okay. And do you know what is the date today?
Sunday.
Okay. Um, Sarah, uh, I'm very sorry to hear your story, and could you please give me time to talk to my examiner? Dear examiner,
Sure.
uh, dear examiner, now I'm going to present the mental state examination of my patient who has come to the emergency department with a history of trying to hang himself, and I actually can't see the patient, but he's very cooperative, and his speech was slow, and volume is also low. His mood is low, and I can see that his affect also congruent with the mood, and he is having auditory hallucinations. And also regarding the thought, he's having his thought form is linear, no loosening of association of light of ideas. He is having a delusion of reference and delusion of guilt, and his insight and insight is impaired. He is oriented in time, place, and person. And I could build up a good rapport with the patient. His judgment also impaired, and he's having a high risk at the moment because he's having active suicidal thoughts and active auditory hallucinations and delusions as well. So he's having high risk, and the history which I was gained from the patient is not reliable because he's having psychotic symptoms. So I would like to get the collateral history from the relative with the consent of my patient.
Thank you, Doctor. Time up. Okay, very good. Very good. Like you have tried your best, Dr. Shanika. That's really nice. And I'm sure like with a little bit more role play, it will become very, very good. Okay. So what was missing is that like I understand that the confidence was not there. Like definitely it's not, it must be your first few role plays.
Yes.
So in those situations, sometimes you will not get that voice or that tone of confidence. It comes with a lot of role plays, and trust me, you will be fine in the next 2 to 3 months. This confidence will be there in your voice. But otherwise, you have done great. You have asked all the important questions. You haven't missed a lot of things that is needed for this case. And MSc presentation was also very good. Okay, so very well done, Dr. Shanika.
Okay.
Few things I would give a feedback is that one, when you first started, allow the patient to talk a little bit. Okay, sometimes we can say a few things and then see if the patient is talking back to us. And then if they don't, then we can talk a little bit more. Okay, so what I mean by that is that initial 1 minute you just talk, you try to make rapport with the patient and so that the patient gets open up with you. But patient did not say anything. So sometimes you can just give a pause and see if the patient is reacting or at least saying something. If they don't, then start saying some more reassuring sentence. That looks very good.
Okay.
And other than that, you missed to ask about how is your mood these days. But when you presented the MSc, you said patient mood was low. So that's very important that if you are saying something that was not been asked, like let's say you can definitely miss asking about the mood question. And when you present the MSc, then you might remember that, yes, I missed to ask this. So in that case, you will just say that, I'm sorry that the mood was not assessed by me, but the affect that I observed, it seems that patient was in a low mood. So the being truthful is very important. Like being honest is very important part of this exam. If you did not assess something, if you say this line that I'm sorry that I did not assess the mood, but the affect that I have observed, it seems that patient was in a low mood, and they will be very happy with you. There will be no problem. But if you say something that you didn't assess, they don't like that at all. Okay? An examiner can easily find that out, as I did. So that's a very important thing to remember. Other than that, I don't think you missed any other specific point. So you asked about all the delusion questions. You could ask about thought insertion, thought withdrawal. Those questions can be asked. And because you were running out of time, you did not bother about asking the SADMA, like home situation, SADMA. Those you did not ask, but that's fine. It's not a part of this case anyway. As long as you are doing all the MSc questions, you will be fine. Okay? So very well done, Dr. Shanika. Any specific finding that you have missed? Not really. You told about auditory hallucination, which was there. you talked about delusion of guilt, delusion of reference, which was there. Okay, so that's also very important.
Thank you very much, sir. Yes, I forgot to ask the mood question, and this is my first role play, and I have just to start my clinical career, so I would like to improve with you, sir, with your guidance.
Yeah,
Thank you very much.
that's totally fine. You did good. You did really good. Don't worry at all. Just keep on practicing.
Okay, sir. Thank you very much.
Thank you. Okay, so what we have got in here, Dr. Sherry, do we need to find out that he is really guilty or is it delusion of guilt? Like, as Dr. Shanika asked, like, do you feel guilty about anything? And then when the patient said, yes, I know, like patient says, yes, I know that I am guilty and I killed the cat. So that's more than enough that this patient most likely has got a delusion of guilt. Now, if you want to like be sure, you can definitely ask that, well, I understand that you feel that way. Was there any committee or any decision made on your patient that they told about what was the cause of death of this patient? Then patient says that, well, the cause of death was natural, but I know that it was not natural. I did the mistake. Now that's the time you can definitely say that this is the delusion of guilt. So you could assess that if you have some time. Should we ask depression question in detail? No need. This task is not about giving diagnosis and differential diagnosis. So in that situation, it's not must. But if they give you a task, in the third task was give diagnosis and DD, then yes, you would have to ask about depression questions. All the depression questions. You had to add some differential diagnosis question at that time. In these kind of questions where there is only two tasks, Dr. Dev, like when there is a MSE and then presentation of MSE, you can just do the MSE component and that's more than enough. Most of the time you will not get any prompt in these cases. So you will need to know when to stop. So all of you got this case, like any questions, anything that you didn't understand. And the good way to explain MSE to the examiner is always include positive and negative finding. Like when Dr. Shanika talked about speech, she could say that his speech was slow and monotonous, but there was no disorganized speech, there was no rapid pressured speech. Same in case of hallucination, when she said that there was auditory hallucination, she could say there was auditory hallucination, but no visual or tactile hallucination. So it's a good idea to include some negative findings as well, so that examiner know that what you are looking for, and they are really happy with this kind of presentation. Difference between delusion of reference and auditory hallucination. It's a total different thing, Sherry. That hallucination means patient is having an abnormal perception. Patient hearing voices. That's auditory hallucination. Patient seeing something which no one else can see. That's visual hallucination. Patient feeling something on the body, but actually there is nothing. Tactile hallucination. So hallucination is a perceptual disturbance, whereas delusion is some kind of abnormal belief. And the belief is strong enough that even though you give appropriate explanation, you have done investigations, and it's coming normal, still patient believe that his or her idea is true. That's delusion. And delusion of reference means when a patient thinks that everyone is talking about him, everything in the street or everyone in the street is talking about what he's doing. Like that means even though actually there is no one is talking, he feels that everyone is talking about him. That's delusion of reference. We already discussed about this class theory session. So today we are not going to discuss any theory. This is all about role play. Many of you who are asking questions, you did not join our first session. In the first session, which was taken on 25th of February, we discussed this MSE, we discussed what is hallucination, delusion. We discussed every component that has been discussed already. Okay, so if you have missed that class, please make sure you first listen to that class and then do this role play. Otherwise, it will not be a very helpful thing for you. Same with SADMA, Dr. Sharina. We already discussed SADMA. It's mainly about smoking, alcohol, or recreational drugs. We don't need to include MMSE in MSE examination. No need. And this patient, yes, this patient has to be admitted to the hospital because this is a high-risk patient with an active suicidal thought. So even if the patient does not want to be admitted, as an involuntary admission, this has to be done. And we will discuss the management of the psychiatric cases, don't worry. How to differentiate between delusion of grandeur and grandiosity. Dr. Jack, that's the same thing. It's the same. Delusion of grandeur and grandiosity is same. Where you can find the last class, the recordings is given in our First Aid AMC Clinical Facebook group. I will show you at the end of today's class. And you want me to present the MSE in this case? I'll do that. Just one second. I just subscribed to the course. Can you give a brief idea how the course will progress? Again, Dr. Mehta, we will discuss that at the end of this class. Let's go on with the class first, and then we can discuss about the course. Okay. That was wrong name, Dr. Alex. I know that. I think it was a mistake. I put 2022 in that class, but that's actually the last class. It has been edited. That was a mistake from my end. Okay, so if we want to do role play on this case, what will you do? Like if we want to do MSc presentation of this one, so you will say, "Dear examiner, I would like to present the mental state examination of my patient who is a nurse brought by his wife because he was trying to hang himself with the rope since a patient died during his care. In terms of his appearance, so it depends what you see in the appearance. So you'll be saying he is dressed appropriate to the weather, he is unkempt, he is cooperative, but not maintaining proper eye contact. He was not showing any sign of responding to some unseen stimuli during the conversation, but he was sitting in a stooped posture. In terms of his speech, he was slow and monotonous, but there was no rapid pressured speech or any disorganized speech. His mood was low, but the affect that I have observed that also congruent with his mood. In terms of perception, he has auditory hallucination, but no visual or tactile hallucination. His thought form is linear. In terms of thought content, he has delusion of guilt because he believes that he has killed the cat, even though it was not the cause of the death. He also thinks that everyone is talking about him in the street, so he has delusion of reference. But there was no other delusion of control, grandiosity, or any thought insertion or thought withdrawal. His insight and judgment was poor, but he was oriented to time, place, and person. He is in high risk because of active hallucination, delusion, and suicidal ideations and plan. But I was able to maintain a good rapport with the patient. But the history that was given is unreliable given he has poor insight and active hallucination and active suicidal thoughts. So I would like to take a collateral history from his wife. Okay, So that should be the MSE presentation. It's a bit big, but you can always cut short based on how much time you have. Okay. Good, everyone. His speech was slow and monotonous. And you can say very slow and low volume. So who is next to do the role play? Dr. Francis, you wanted to do, right? So let's do with Dr. Francis, then Dr. Roha. So I'll unmute you, Dr. Francis.
Yes, sir. Good evening, sir.
Good evening. How are you?
Fine, thank you, sir.
Okay. All right. We'll give you the case just in a bit. Give me 1 second. Okay. So this is your case, Dr. Francis. Your 1 minute 30 second has started. All right. So this is your patient, David. You can start.
Hello, David. My name is Dr. Frances. I'm one of the medical officers in this emergency department. It's nice to see you, but I can see from the notes that a policeman brought you in here. David.
Yeah, I just don't understand why, because I'm okay. And why they're just like taking me from the street. I was not doing anything. I was just hanging around, talking to the people. But I don't know why they brought me here, doc.
Oh,
This
I'm
is
so
just a waste
sorry
of
about
time.
that. I'm so sorry about that, David. I'm very sorry. I'm sure they did this to just help you. So please don't be too angry about that. If you can
I
tell
don't need
me
any
more.
help. It's fine. As I say that I'm okay. There is nothing wrong with me. I've been on the street for a long time. I know the street, and there is nothing wrong. It's just like I don't know who has complained or what happened. These police, they just want to bring everyone to your ED. They just waste your time, dog.
Oh, so sorry. Please don't be too disturbed about it. I would also want to reassure you that everything you're going to do here is going to be confidential, and you don't need to think about the police officers anymore. Please don't worry about it, okay? Unless I would have to involve other
So
people.
you're saying that I'm not in a trouble. They're not going to take me to the jail,
No,
right?
please, no, please, no, please. You're not in any trouble. I assure you, they brought you in here for your own good. Don't worry about it too much, okay? Okay, baby. Okay,
Okay.
that's good. Can you please tell me more about yourself? Is there anything that is of concern to you at the moment aside the police bringing you in here?
No, nothing. As you said, I'm fine. I'm okay.
All right. But how has your mood been of late? How have you been? Your mood and everything, how's it been of late?
Yeah, it's okay, as it can be for someone who lives on the street.
I can understand that. I can understand. And what about your sleep? Do you sleep well, David?
Sometimes, yeah.
Okay, you don't have any issues with your sleep.
No, not really. I'm okay.
Okay. I can also see from your notes that you have an ulcer on one of your legs. Which leg exactly, David, please? If you can please help me out with
What's an
that.
ulcer? I don't know any ulcer. What is
Like
ulcer?
a
I don't know any
wound.
ulcer.
If you have a wound, I
Wound?
can
What
see
is
from
the
the notes that
wound?
you have a
Oh,
wound, like sore. Do you have any
no.
sore on your leg?
Oh, okay. Okay,
You don't
there
have
is
any sore on
one. I
your
didn't
leg?
notice that.
Okay.
Yeah, I can see
Did,
that now, but I don't know how it happened. How long
okay,
it's
that's
been
so
there? Oh
sorry.
my God. It's a bad sore.
Did you experience where was your body hot with this? Did you ever experience any hotness of your body
No,
with this? Okay, that's
not really.
fine.
I didn't even know that there is something in here.
Oh, okay. That's okay. No worries. No worries. I'm going to make sure that this is going to be sorted out. Okay, David? No worries at all. Um, do you eat well, David? How has your feeding been? I know you are
Hard
I
dog. I don't
mean,
have.
mhm. Yes, I'm listening, please.
It's
I'm listening
hard.
to
I
you,
just
David.
live on the cent in the cent in the. I just live on the central link payment, so I try to eat
Mm-hmm.
as I can.
Mm-hmm. Okay, but you don't have any issues with eating. Do you eat a lot or have you lost appetite?
Mhm.
Mm-hmm.
No,
Okay. Since you were brought in, do you take any drugs at the moment? Do you do anything? Do you take any alcohol? Do you smoke? Do you take any drugs whatsoever?
I drink alcohol sometimes, but
Okay.
no other drugs. I can't afford it.
Okay. How much alcohol do you take in a day, if I may ask, please?
Sometimes, like when I get the central link payment, I can buy maybe
Mm,
like 1 or 2 bottles of wine, and then
okay.
I try to drink that as much as I can. But then,
Mm,
like for the last 5 days, I couldn't drink anything because I don't have any money.
okay. 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 No worries. Thank you so much. Um, do you think your life is worth living, David?
Yes, yes, definitely.
Okay. Have you ever had any passing thoughts of committing suicide?
No, dog. Yeah, it's a
All
shitty
right.
life, but I want to live.
All right. That's very good to know. Um, have you ever in previous years or days, have you ever tried committing suicide or attempted it actually?
No, dog. No.
Okay, no worries. Thank you so much. I hope these questions are not actually bothering you, but I would want to ask you a few more questions. That is just by way of getting to know if there's any other issues with you. Is that okay with you, please?
Sure.
All right. Please don't be scared about the questions I'll be asking you, and then don't actually think that it's a way to make you feel bad.
No
Okay, is that
worries.
all right?
You can ask me anything. You
Okay,
can
no
ask me
worries.
anything.
Thank
I'm not
you.
scared.
All right, thank you so much. Do you actually see, feel, or hear things that others do not?
No, as you're asking, I don't know like if others can also do that, but
Mhm.
sometimes I can see some dead people. I don't know
Okay,
like if I dream or even sometimes when I walk, I can see like the people on the other side. And
okay,
it haunts me sometimes. I feel like they
okay.
want to talk to me.
All
But don't
right,
think
okay.
I'm crazy or something like that.
Not
I
at
know that I'm
all,
not crazy.
not at all, not at all. As I reassured you that anything I'm going to ask you is just by way of finding certain things to also help you. So please don't worry, and please don't hesitate to also tell me anything that you want to. Has there been any way that you felt others are also talking about you,
No,
or people said anything about you? Let's say feeling that people are controlling you.
no,
What about you feeling guilty of anything whatsoever?
no,
Okay. Do you feel you have any superpowers?
no. Time up, doctor.
Wow,
Okay.
my timing.
Yeah, it is hard. This kind of case can like role player can carry away like every time that you have. You just need to take control of this case, okay? Because if
Okay.
you the thing is that you you can't be too much concerned about the approach also. It has to be in the middle. Like I know
Okay.
that your approach, your way of talking, everything was very, very good, Francis. The main problem was that like you took a lot of time just to reassure the patient, just to say sorry and thank you. Now it is very important. Definitely it is really important, but it can't take too much time. Okay. So
Yes, sir.
and also the relevant questions. In this question, the suicidal thoughts, those are not that much important. This patient hearing dead voices, like dead people voices, seeing dead people, which means that it is a psychosis. Could be a visual hallucination from alcohol withdrawal, like it could be a delirium tremens, because patients say that for the last 5 days he couldn't drink anything. So that's one of the possibility. So the main purpose of this is that understanding which is important and removing things which is not important, like sleep, appetite, not very important. But important is to ask the mood, ask about just one question is enough. Do you think life is worth living? If patients say yes, you move on. You ask the next question. And during that time when you are asking about the hallucination delusion question, you explained a lot. It's not needed. You just say that, David, I'm going to ask you some questions which might seem a little bit strange to you, but please be aware that is a screening question. That's it. And then you move on. Okay. So
Yes, sir.
then you will get the findings. You will have to ask how long you're feeling this way and gradually ask all the delusion questions. And that is the way to finish this case in time. Because you can easily get carried away. They can start saying a lot of things, but that's not important for you. You have to take control of this case if you want to finish it in time. Otherwise, like if it is a mania case, they will just talk and talk and talk. If you don't know how to take control, then that case will be failed. Okay.
Yes, sir.
So
Thank you
important
very
to
much,
get
sir.
this idea that when to like go faster, when to be slower. That's important, and it comes with a lot of role plays anyway. So do a lot of role play of these cases because this is like a paid case. You will get this kind of case in the exam, so you have to do it. And in terms of MSc presentation, what are the findings that you get in this patient so far?
So far, patient didn't seem to have any insights in his condition. He had auditory and then visual hallucination. I think I would say that his speech was also fast and a little bit pressured. Aside that, I don't
This
think I
was
was
not
able to
like a
pick up
fast
anything.
and pressured. Yeah,
Okay.
no, that's okay. This is not the fast, like a rapid pressured speech. You will see the case
Okay.
when it will be rapid pressured speech. This you can say it was normal or maybe a bit high, maybe a little bit of, sometimes there was change in tone and voice pattern.
Okay.
That was the only thing, but otherwise it could be fine.
Okay.
Yes, you couldn't find about anything else. That's right. This patient's mood, patient said, yeah, it's okay. And you'll have to say that according to the patient, mood was okay. But the
Okay.
affect that I have observed was not congruent with his mood because the affect is disturbed. This patient is disturbed, right? So you had speech, we said perception, auditory and visual hallucination was there. Delusion, if you ask about thought withdrawal, then you will get this finding positive that the patient will say, yes, I feel my thoughts and thinkings, someone is taking it away. Like people know about what I am thinking. So that will be a thought withdrawal. That was one of the positive finding. And other than that, insight would be impaired in this case. Judgment would be impaired. So when you ask those questions, you would get this finding anyway. All right?
Yes, please. Yes, please. Thank you, sir.
Yeah. Thank you, Dr. Francis. Any questions from any of you?
Sir, please, sorry. I want to find out in terms of the approach that I use, aside explaining and showing probably so much of empathy. Is there any other thing that I could do in preparation to these questions, please?
I don't think your approach is bad at all, Dr. Francis. I think like you just need to take care of the time. Otherwise, you are doing really good. You're asking questions, all are appropriate. The main thing to understand is that what is more relevant in terms of a particular case. Like the case that we discussed in the first one, that was depression case. That case, mood, sleep, appetite, suicidal thought, those are more important than delusion question. But for something like this case, psychotic or delusion hallucination questions are more important and more relevant. So you have to focus on the relevant part more than something which is not very relevant.
Okay. Yes, sir. And then,
but otherwise, you are doing really good.
Thank you, sir. The ulcer, I asked about the ulcer, and was it important to have asked?
Yes, it was important, and you did really good to say that you will take care of that ulcer. A lot of candidates don't say that, and that is a very bad point. Because a patient coming to you with an ulcer and he doesn't know about the ulcer, that's also quite risky. So you just need to say that, yes, I can see there is an ulcer on your leg. Do you know how long it is there? Patient might say, I don't know, doc. Where is the ulcer? You will say, well, yeah, that's on your leg. Then patient will say, yes, I can see that. Then you will say, please don't get scared. You are in a safe hand. We are going to take care of it. That's it. Just make it. This is one point in the question that you covered it, and very quickly you move on to your MSE.
Yes, sir. Okay, sir. All right, sir. Thank you very much, sir.
Thank you, Dr. Francis. Okay, so Dr. Sherry, how is the mood was disturbed? Disturbed mood means that psychotic patients, their affect is disturbed because it means that the patient was not talking like a normal person, right? I think you could get that from the way of talking. It's not a normal way of conversation. So that kind of conversation, it shows that patient definitely not okay. This patient's mood cannot be okay. So it is disturbed. So in a psychotic patient, you can always say that their mood is or affect is disturbed. In the assessment, do we need to do physical examination of the venous ulcer? No need. It's not your task in here. What about the ulcer? As it says, relevant assessment. So you'll just say that you are going to take care of it. That's it, nothing else. Can you please repeat the question you can ask regarding thought withdrawal? So Dr. Aditi, we will say that, do you think that someone is withdrawing thoughts from your mind? Okay. Do we need to ask about ulcer pain? You can ask it, like you can say, is there any patient doesn't know about that there is an ulcer there. So definitely there is no pain. That's why I didn't bother about the pain question. Okay. And if, yes, you can say he seems to be a bit distant. Yeah, because he did not even notice his ulcer. What is the importance of venous ulcer in this question? It's not the important point in here. It shows that some lack of insight is what you can see in this patient. This patient has got an ulcer, but patient does not even know about it. And that is what you find out in an active psychotic patient, because they don't have insight to know about their condition. And this one, Dr. Nauf, we are not going to discuss the full MSE today because it has been already discussed in the class. How to take history for this kind of cases. So you need to start. If you haven't joined our first class, you need to do that because the questions are same. We already gave you a format of mental state examination, and you need to follow that. So questions will be pretty same, and the assessment means that they're taking the history. So the psychosocial history that we have discussed, that is what you need to do in this case. So first you greet with the patient, and then definitely you will need to give confidentiality to the patient, that everything is confidential. And then you can ask one by one that, can you tell me a little bit more about your mood these days? So you'll ask all the questions according to the format. And Dr. Francis, you did not give the confidentiality. So you have to give confidentiality at first. I think you have given in the middle. Do we need to ask about heads? No, no need. Again, Dr. Amar, relevant. Relevant question is important. In the heads, even for the task like just presenting the MSc, the heads are not super important. So you can omit heads and SADMA. It's not must to do in this case. Okay? So definitely employment education has nothing to do with this case. It's not the most important part. And this, yes, definitely, this is not a rapid pressure speech. You will see what is rapid pressure speech. But you can say, Dr. Dev, that patient tone was fluctuating. That you can say. And asking about medical history, definitely we can talk about it. But again, you can see that Dr. Francis was not able to finish the case. Even she did not ask those questions. So you will not get a lot of time in the exam to ask everything. That's also important to understand, that how much you can ask. For this patient, definitely in a real scenario, we would ask about diabetes. We will try to rule out peripheral neuropathies. A lot of things we would ask. But for this particular case, your task is to just do the assessment, present MSc. So main thing is to ask history related to mental status exam so that you can present it to the examiner. So your main focus will be on that. Don't get carried away with a lot of other things. No need that. We don't need to know that from where he is from. Not needed. What is the time for each task? So time for each task, 2-minute reading time and 8-minute to perform the case. Okay, I can't do the case, but there is no one to give me information. Like someone needs to do the role play with me so that if I need to do this case by myself, but there is no one in here who can do that. That's the problem. So I understand the problem what you guys are facing, that you want the a step by step approach. But we already discussed the MSE theory. I feel that many of you who are having the trouble, you didn't do our first class on the MSE presentations or even how to take a psychosocial history. And there is nothing to be confused, Dr. Fariha. The thing is that your task matters most. The task is about psychiatry. So we are not quite concerned about the medical part of it. Okay? Just because they have given us this patient has got a venous ulcer, that doesn't mean that we will need to focus on venous ulcer. The task matters in the exam. The task is psychiatry related task. And only thing matter is psychiatry, but touching the point that yes, you're going to take care of it. Because you haven't got to 30 minutes or 1 hour to treat this patient in the exam. You have only got 8 minutes. And in the 8 minutes, you only focus on the most important things. Okay? All right. Who wants to do the next role play? Now, before we do that, let me explain how I would do this case. Okay, let's see that if we can just give you a bit of understanding. And to do that, we will go to that MSE theory session so that you can also relate that what we actually have discussed. So let's say that first of all, you have got this patient David. So you will say, "Hi David, this is Dr. Arshan. I'm one of the doctors in this emergency department. It's very nice to meet you. How are you feeling today?" Patient will say that this happened, police has brought me here, I'm quite worried, blah, blah, blah. You will reassure the patient that you are here to talk about this, not about the police. So you'll say that, "David, I understand that you must be stressed and upset about the police bringing you here. But I'm sure that I can help you with this. All they want to know that if you are safe to go back to the street. And with my assessment, I can discharge you back. I can discharge you and you should be fine with that. So I need to ask you a few questions regarding anything that police might be worried about. And I want you to know that whatever we are discussing here, it is confidential. I'm not going to disclose any information to the police or anyone unless it is harmful for you or others. And I want you to know that this is a safe place. There is nothing you need to feel that you will be judged or embarrassed about. So, David, tell me that, like, how is your mood these days? You feel okay? How is your sleep and appetite? Do you think your life is worth living? David, I'm going to ask you a few strange questions, but please be aware that these are screening questions that I ask to anyone with similar presentation. So, David, do you see, hear, or feel things that no one else can? Then you will get some finding in here and you'll need to ask some questions regarding that. Do you think someone is spying on you or trying to harm you? Do you think someone is controlling you? Do you think you are guilty of something? Do you think you have some special power? Do you think that someone, or let's say the people in the street, are always talking about you? Do you think that someone is inserting or withdrawing thought from your head? Do you think TV, newspaper has some special news about you? So these are all deletion questions. Then you'll say, David, do you think you need some professional help or medical help? If there is a fire in this room, what will you do? Do you know who I am? Do you know where you are at the moment? Do you know the day do you know the day today? Okay. And if you still have some time, you can quickly ask about homes like Heads and Sadma. So you already know this patient live in the street. So home situation, there is nothing you need to ask. So you can ask that, do you have enough support? Do you drink or smoke any recreational drugs? Any other medical or psychiatric history in the past? Then you will thank the patient, go back to the examiner, present the MSE to the examiner. Did it take a lot of time? No, not really. I can finish this in 6 minutes. And that's all that you need. 6-minute history, 2-minute MSE. All good? Dr. Faria, did you get an idea that how it should be done? And yes, recreational drugs, again, if we have time, we can always ask questions. Okay, Dr. Roha, you can unmute yourself.
Hello, sir.
Hi, how are you?
I'm good, thank you. How are you?
I'm good, thank you. Okay, let's do a video MSE. Okay, so Roha, Dr. Roha, you are going to do a video MSE where we are going to show you a video of conversation between a doctor and a patient. You will find out the important information from that, and then you'll present the MSE once the video is stopped. Okay?
Okay, okay.
So this is your case. Read this case, and then we will start the video.
Yeah, great.
All good?
Yes.
All right. So let's start it.
Hello, Robert Smith.
Yeah.
Thank you for coming to see me today. I'm Dr. Stanley. I'm one of the doctors that works here. Obviously, anything that we say is confidential between us and the team that I work with, and your GP who's asked me to see you.
Okay.
I hear there've been some problems with your housing. Do you want to tell me a little bit about them?
Yeah, I've had all sorts of problems. I mean, where do you want me to start? My neighbours, police, people spying on me in my street. None of them will admit to it, but my neighbours, it's mainly them at number 9, but I've seen them talking to the ones at number 6 and across the road as well.
So when did things start to go wrong?
I don't know. I mean, you'd have to ask them. Well, like when they started properly, like deciding that they wanted me out of the street. I think it was a few months ago. Months. It's been going on for months.
What makes you think they want you out the street?
Well, it's the harassment. It's the spying on me, putting bugs in my house, in my phone. And that at first they thought I couldn't hear it, but now they know that I know that they're there. Saying things about me through the window. Talking about what I'm doing. I know they're doing it. Whenever I leave my front door, woman at number 7, she's always there. She's clocking where I'm going and what I'm doing.
Why do you think they're doing that?
Well, I don't know. They just. I think they want me out.
Mhm.
I think they're testing me, and they're trying to find out how far they can push me. Basically, it's all part of some test. I don't know why. I don't know what for. You know, you'd have to ask them. That's what I've said to the police time and time again. I've said to them, why are you asking me these questions? Why don't you just talk to them?
You said that your phone was clicking. What was that about?
A landline.
Your landline.
Yep. Somebody rings me or I ring somebody. Between 7 and 10 seconds in, I hear click, click, click. Click, click, click every time.
Any other explanation for that?
I don't know. Well, it could be, but you know, every single time, and then they're talking to me, and then they know what I've been saying down the phone. You know.
How are they talking? Where are they talking to you?
Well, I can hear them next door. Always on the phone again. Always reading that book again. You know, I can hear them saying it, and they know that I can hear them, and that's why they're doing it.
Okay, so just to summarise at this point, your phone's something's happening to your telephone. You can hear your neighbours talking about what
Yep.
you're doing, making a commentary on your actions
Every day.
every day, and you feel that there's some sort of reason for all their actions doing this. Any other things that you've got problems with?
Following me down the street. People following me when I'm going to the shop. You know, it's happening more and more. It's happening more and more. I mean, I've tried to explain to my friends about it. They get really agitated. They think I'm off my rocker, but they don't see it. You know, they're not living with it every day.
Okay.
You know.
So your friends are worried as well?
Yeah.
So
Well,
they've-
worried or I mean, I don't think they're on it. I don't think, but they know a lot about what's been going. I don't know. Maybe the police have been talking to them or something, or maybe my neighbours have been talking to them.
Okay.
I don't know. Again, you know, you'd have to ask them. But you know, it's hard to know. It's hard to know who to talk to because they all, you know,
So
they're all involved.
So this started happening a few months ago. Has it had any other effects on your life,
Well, yeah,
such as?
can't really go out. Well, I can, but I know what's going to happen if I do. So I'm just trying to stay low key. You know, I'm trying to stay out of people's way. You know, I've hardly slept. I've hardly slept for the last, I don't know. I can't remember the last time I got more than 4 or 5 hours sleep.
So what disturbs your sleep?
I don't sleep until. I don't tend to go to sleep until after 2, 3. When I'm sure that they've turned everything off.
Right. Okay.
You know, downstairs, and just can't. You know, I'm worried about it.
Any problems watching the telly, listening to the radio?
Oh yeah. They're using the TV as well. They're using all. They've got all this technology, obviously. I mean, I know there's all these smartphones and whatever now. You know, all they need is one of them, and they can just. But yeah, TV. You know, they've got the local news. If ever I watch that, you know, there's always some little comment. There's always something they say in there at the end about what's been going on. You know, pretty much every time I turn the TV on now.
Okay.
I mean, it's all just the cable, isn't it? So they could, for all I know, they've just plugged it into that.
What do you mean the cable?
The cable TV, you know, it runs down the street. You know, everybody's got access to it if they know what they're doing. You know.
So obviously, this is all very distressing. All the different things that are happening.
All right, so that's about this. You can now present the AMC.
Yeah. Your examiner, I would like to present MSE of my patient Robert, who had some problems with his housing. So he appeared to be well dressed and well groomed. He was cooperative and was maintaining good eye contact. But he was sitting in a stoop posture. I could notice that. And his speech was kind of pressured, rapid, and loud, a bit loud. Also, he was like the emotions, the mood was not assessed, but I could see that he was disturbed with all the things going around. The perception, he was he was having active auditory and visual hallucinations. The thought form was linear. It was not, there was no loosening of association of flight of ideas. Um, uh, the, uh, uh, the delusions he was having were the delusions of a reference, persecutory delusion, the thought withdrawals, delusion of thought withdrawals, delusion of broadcast. The insight and the judgment and cognition was not assessed in this video. He seems to be a high-risk patient because he was having active hallucinations and delusions, and the doctor was able to maintain a good rapport, and the history was not really reliable because he was having active hallucinations and delusions. So I would like to take collateral history from any of his friends or family. Thank you, Doctor.
Perfect. Thank you, Dr. Roha. It was really good. So everything you have covered, but on the appearance, did you see that he was looking at some point in that room as if he was responding to some unseen stimuli? So that was one thing that you could say. I'll show you where it was. Yeah.
Oh, I didn't notice. So yeah.
Let's see.
Say is good to see you.
Okay.
Dr. Stanley,
See?
I'm one of the
Yeah.
doctors.
That was the time.
Yeah. Thank you for coming to see me today.
Okay.
I'm Dr. Stanley.
Okay. So that was like, it's not just a one time, he has done it 2 or 3 times. So he was responding to some unseen stimuli. That's one thing very, very important in this kind of cases, not to miss. A lot of time this will be the finding in the exam. So that's one thing in the appearance. Speech was rapid pressure, you can say that. Emotion, you said it was not assessed, so very good. And it was disturbed according to you. Perception, this patient had only auditory hallucination, not visual. Okay.
But
So-
he could see people
On the
following
street.
him. Yeah, on the street. The people were following.
Yeah, now that's not a hallucination. We can't be totally sure because a lot of time, like there might be people behind him, and he thinks that people is following him. There is actual people might be behind him, but he's thinking that he's being followed. So that can happen, and that's why we would not say that is auditory, that is visual hallucination. So people following him, sometimes it can be like he just feel it, but there is actually they are just behind him. Okay, so only auditory hallucination will be good, no visual or tactile. Thought form was linear. This patient had delusion of persecution, delusion of reference, as you say. Yeah, it's very good you say that there was a thought withdrawal, because we can say that because the neighbors always know what he's doing or what he's thinking. So yes, we can say thought withdrawal. Thought broadcasting, because TV newspaper has something for him always. So you can say that also. Insight, cognition, judgment was not assessed. This patient is a high risk, and rapport was well maintained. And yes, you will need to take a collateral history. Very good. You haven't missed any important things, but except that appearance part and that hallucination part.
Okay. Thank you, Doctor.
Thank you.
So, Doctor, does he also have slurred speech?
No, we would not say slurred speech in here. It's fine.
Oh.
It's just like pressured.
Yeah, pressured and rapid. Okay.
Yeah. And Dr. Amar, can we add paranoid delusions here? No, persecutory or paranoid delusion is same. Like people are spying on him. Yes, this patient has a delusion of persecution. Delusion of persecution and paranoid delusion is the same one. So you can use any term. This class will be accessible later on. We will give the recording. That's right. Can we write down the points in the exam? Yes, you can. So when you are looking at the video, you can write the points on a paper. So that's possible. I always say write aseptic J3R on the paper and in front of that, just write the positive findings that you have got. Now, that's right, Dr. Sharina, that the way he was looking around, it could be that he is seeing something, but the problem is that was not assessed. So we can't just say that there was a visual hallucination on that part.
So how would we comment about him looking around in the room? Like what would we say when we are presenting this to the examiner?
So on the appearance, we will say that he was responding to some unseen stimuli. That will be the main thing that you can say. He was responding to some unseen stimuli. Did the patient say that he is worried? Now, yes, he did say that, but that was not as part of the question of mood. So we can't say that mood was worried. Better just to say it was not assessed, because this examiner did not ask that how is your mood these days. Yes, they can show video cages also in the exam.
Sir, like the way I said that the mood was not assessed, but he looked a bit disturbed. Is that okay if we just add this? Okay.
Yeah, that's what you're supposed to say. It's good.
Okay.
And can we say that he looks anxious? Yes, we can say that. He looks anxious and worried. So on the appearance, you can add that. If the doctor here didn't ask about insight, can we comment on insight? Not really. So if something is not assessed properly, then we would not comment on that. But there is no restrictions on anything as long as you can explain it and you can give a logic behind it. Now, if you say that the insight was not assessed, but during the conversation, the answers and the way of explanation, it seems like the patient does not have insight. Now, if you give a logic behind your understanding, that's always fine. So it's not like it's a restriction from me or anyone, but as long as you give a proper explanation of what you are saying, you will be fine. Okay? All right, so you're getting ideas about the role play, I guess. We'll discuss another case now. All right, Dr. Sherry, you can unmute. Dr. Sherry, you can unmute if you want to do the role play.
Yes, doctor.
Yeah, I can hear you.
Thank you.
How are you?
I'm fine, thank you.
Okay, good. Let's discuss one of the other cases. Okay, doctor, so this is your case. Your 1.5 minute has started.
Yeah, doctor, I'm ready.
All right, now so this patient is Sam. You can start.
Hello, Sam. I'm Dr. Sherry. I'm one of the doctors here. I
Oh,
understand
doctor,
from the
let me stop you there, doc. I've got a lot of interesting ideas that I want to discuss with you. This is a good time to discuss? You are not having like you need to see a lot of people. But what I want to talk to you, doc, is that I've got a brilliant idea at the moment in my head. I think that there is some flaws in Newton's first law, and the world is going to be surprised about it. I think also like I've got like a lot of good ideas about solar system, which no one else can even think of. And you know that the school counselors, they're just stupid. They don't know anything that I know. So they're just jealous of me. So that's why they asked me to come here. But I'm saying, doc, I'm totally fine. I'm feeling fantastic. I feel like so much energy in me at the moment. And I just think that it's just a waste of time for me to come here. I've explained myself, doc. You can just send me home. I just need to write everything that I'm thinking, because if I stop thinking, then all this important information will be gone from my head, and you don't want that.
this is
So
nice
can
to
I
hear
go
all
home?
that from you. Sam, I would like to ask you some question to be able to explore the situation more. Can we discuss a little bit more?
Doc, there is nothing to discuss. I have to go because, as I say, that the school counselor, they just want a letter from you, and you can just write that I'm brilliant and I have got a lot of ideas. So it's like understandable that I will be a little bit like off these days. So they just need to understand it. It's for the brilliant,
Yeah.
and it's for the importance of this world. I need to think about it. I need to write all of this down.
I appreciate all your thoughts, Sam, and I will not take a lot from you. It's just a little bit of minutes, and I would like to reassure you that everything we discussed today is confidential between me and you, unless it's harmful to you or others. Is it all right?
Yeah, that's fine. That's fine. Doc, do you know about cryptocurrency and the bitcoins? Like, there is some interesting thing, and you can be millionaire in a day. So all these ideas I have already bought like a lot of shares in cryptocurrency, and I think I'm going to be billionaire. And if you want, I can also give you some of these thoughts, but definitely not the whole thing. So that's also one of the other thing I'm thinking right now. And I've got a lot of shares. That's also I want to buy now. So as you can see, I'm out of time. I have got these thoughts and it needs to be done. A lot of thinking at the moment, and I can't just keep on focusing on one thing.
I appreciate that, Sam, but I would like to ask you, how is your mood?
I feel fantastic.
Okay, this is good. And Sam, there is some question that might seem strange, but it's only screening question. So do you see or hear anything that others don't?
Oh, dog, I'm not crazy. I know you were thinking that, but I'm not a crazy person. Just because I have got all this information doesn't mean that I'm a crazy person. It's just like I know this.
I'm sorry, Sam, it's just a screening question that I ask it to everybody. Do you feel anything that others don't?
No,
Sam, do you think others are controlling you?
no one can control me.
And anyone, do you think people are talking about you?
Yeah, everyone is talking about me. The school, the counselor, even the teachers are talking about me because they don't know what I know.
Yes. So you think you have a special power.
Yeah, definitely. I am brilliant and I know better than Newton. So I have power.
Okay. And do you think others are spying on you or trying to harm you?
No,
Okay. And do you think others are inserting thoughts in your head or withdrawing thoughts from your head?
no, I will not let them to do that.
Do you think your thoughts are broadcasted in the TV or radio?
No,
Do you think you need medical help?
no. Why? Why would need medical help? I'm perfect. I feel good. A lot better than what I was before.
And do you know who I am?
Yes, you are the doctor.
And where we are?
In the hospital.
And what day is today?
Sunday.
Okay. And if this room catch fire, what will you do, Sam?
I will definitely run. I have to live.
Okay, and how long have you feeling that others are spying, that others are talking about you, and that you have special power? How long have you feeling like that?
Just for the last 1 week.
Okay. Can I ask you about your home situation, and if there is any stress in home or school?
No, I live with my parents, but yeah, we are a happy family. They are also worried about me, but they don't understand my brilliance.
Okay. Do you smoke or drink alcohol or take any recreational drug?
No.
Okay. Now, Sam, I would like to go to the examiner. Is it all right?
Okay.
Dear examiner, I would like to present Sam, who brought by the school counselor because of downgrading of his performance. His appearance cannot be assessed. His speech was pressured and rebelled. He said his mood was fantastic, and the affect I observed is congruent with the mood. He does not have any auditory, visual, or tactile hallucination. His thought form was linear. He had delusion of jealousy, delusion of reference, but no delusion of control or he had also delusion of grandiosity, but there is no delusion of persecution.
Time out. Please continue.
There is no delusion of persecution or thought insertion or withdrawal or broadcasting. The insight was poor. He was oriented to time, place, and person. The judgment was kept, was good. I could build up a good rapport with the patient. The risk was high because he has active delusion. And I would like to take a collateral history from his family member because he has active delusion and he has poor insight. The diagnosis.
Thank you, doctor. What's the diagnosis?
For 1 week. The delusion was only for 1 week, so I think it's a schizophrenic disorder. And
okay.
Because he is a high risk, so I wanted to admit the patient and do
it's
full
fine. It's not the part of the task. It's
there is
fine.
diagnosis.
We don't need to. If there is
differential diagnosis.
Yeah. So when there is diagnosis and DD, no need of talking about the management. So you have to explain what is the diagnosis and then give some differential. So why we think this is a schizophrenia form?
Because it's 1 week, so to diagnose the schizophrenia it needs 6 months, and there was delusion, and it might be mania as well, because he has rapid pressure speech, and he feels fantastic. This was
a mania case. Okay, so patient having rapid pressure speech, he thinks you see that rapid change of his focus. He was just jumping from one topic to another. And he's thinking he has a special power, delusion of grandiosity was there. And a lot of time these patients think that people are talking about them. And that doesn't make them psychotic patient. So this flight of ideas, these changing topics, how he is talking, that makes it mania more than schizophrenia or schizophreniform. Okay, so the main thing is that he was talking about a lot of things, and psychotic patients, they are focused on a specific point, not just like a lot of things jumping like this. Okay, and the main other point is that if you ask all the mania
flight of
questions
ideas.
in here, flight of ideas was here. That's right. So the other thing is that if you see that there is a diagnosis and DD, and you have to ask mania questions in here, and if you ask it, you would find everything positive. This patient, when you ask about sleep, he will say that he doesn't feel like to sleep. So that's one of the other things that we get. Did we discuss about mania findings in the class yet? I don't think we did. So it's called dig fast. So this is one of the mnemonic that we follow when we are thinking about mania. We will discuss that in our course, but just for your understanding that what is dig fast is a mnemonic that we use to diagnose mania. So D for destructible. They will be quite destructible, as you could see in this patient. He was quite distracted with a lot of information. Impulsivity. So impulsive means they will spend a lot of money. Like this patient spent a lot on bitcoins, cryptocurrency, and other things. They can go out and have binge drinking, lots of recreational drugs, maybe having sex with unknown people, reckless driving. So all of these are part of impulsive behavior in this patient. G for grandiosity, which you have found. F for flight of ideas, which was there. A for increased activity. So there will be increased goal-directed activity. They will join in a lot of clubs, maybe join in the gym, maybe they will be doing a lot of goal-directed activities. S for lack of sleep. That means no need of sleep. And T for talkativeness. So they will be very talkative and loud, which like everything was there in this patient. So when you ask these questions, so few questions. One, you can't ask destructibility. You have to see it. I, which is impulsivity, then patient already gave you all the information like spending money, buying shares and everything. But if they don't give it, you will have to ask that, are you spending a lot these days? Okay, any history of like binge drinking or taking any recreational drugs? So those questions you can ask. Grandiosity, we're asking about, do you have any special power? F for flight of ideas, which patient will give it to you anyway. Activity increased. If you don't get it from the patient, then you just have to ask that, have you enrolled yourself in a lot of activities these days? Are you doing a lot of goal-directed activities these days? So any questions will do. When you ask about the sleep, patient will give you that finding. And T for talkativeness, which again, when patient talks to you, you will get it.
Doctor, I have a question.
Sorry, I think Dr. Moshumi, I just muted you. But you can unmute again.
So regarding impulsivity, the mania patient has a tendency to like binge drinking or drug abuse or recreational drug uses. But is there any chance they will lie about that, or they will jump into the other other type of answer when we ask them?
No.
Or will they
No.
directly answer? If we ask them, do you have any habit of smoking or drug abuse or alcoholism? Will they answer directly, or will they? There's a chance
They
they
will
will
answer.
hide that?
They would not, because they brag about it, and they usually are very happy to say all of these happy things that's happening with them. Okay, so they will not lie. They will definitely say everything. As I did in this case, I said everything that I have been thinking. So most of the time, they will give you all the information anyway.
Okay, thank you, doctor.
So this case was mania because more than equal to 1 week of these symptoms. So if there is at least 5, if there is most of the symptoms presenting more than a week, you can give the diagnosis as mania. Okay. So hypomania if it is less than a week. Other differential diagnosis for this case, you can then give that it could be brief psychoactive disorder, it could be schizophreniform disorder, it could be drug-induced psychosis, substance abuse disorder. You can give bipolar disorder. Okay, so this will be your differential in this case. So what are the findings in this case that we have got? So this patient mood was fantastic, speech was rapid and pressured, and then in case of, there was no hallucination, definitely. Thought form, this patient actually had flight of ideas, and then thought content, this patient had delusion of grandiosity, delusion of jealousy, and even you can say delusion of reference because everyone is talking about him. And then insight was impaired, judgment, cognition was fine, and definitely this patient is a high risk because of lack of insight, active delusion, and rapport was well built. And then this patient, you need to take a collateral history from the family member or school counselor. Now, Dr. Siddhant, as you did see that Dr. In these cases, you have to allow the patient to talk. Like Dr. Sherry did, she did not interrupt. At some point, the role player need to take the breath, right? Like no one can talk and talk. They need to stop at some point and take a breath. When they do that, then that's the time you go in. Okay, you take the chances.
So, Doctor, distractibility, this patient was distractible by his thoughts. So I can say he is distractible, or what is the meaning of distractibility in Hindi?
It means that his patient will be like talking about a lot of things, not having a specific focus. That's distracted.
Okay.
If we
Thank
do
you.
not make the right diagnosis, will that be fail straight away? There is a likely chance it will be fail. The marking in the exam depends on not only one part, it depends on the whole thing. So I haven't discussed with you how the exam mark usually happens. So all the tasks that you get, these are marked as 0 to 7. Okay. Say, now let's say someone has got 4 in the history, 4 in the MSE presentation, but 0 in the diagnosis and DD. When they do the average, that will be fail. When it is pass, if the global score is more than equal to 4, that's a pass. It's not always that they make an average of these 3 tasks. Sometimes your approach and how the role player feels about you, that also affects the global score. Okay? So definitely you need to at least, if this patient, like let's say you have got 4, 4 and you have got a 3 in here, then still you have got a chance that if the role player is happy with you and your history and MSE presentation was very good, then examiner can give you a 4. If you get 4, you will pass this task. Let's say someone has got 6 in the history, but MSE presentation was 2, diagnosis was 2. Now that can also come as fail. So it's not always about making the average. It's all about the whole scenario. If you do really good in one task, but other 2 tasks are not good, it doesn't matter. You will fail that case. Okay? So your main focus should be getting 4 in each task. So it means that you don't need to say everything in the history. At least get a 4, and then you can at least pass the case. And that's it. That's what you need to think when you prepare. Good, very good point, Dr. Gayatri. There was a point when the patient said, I'm feeling better than before. Yes, definitely we could ask that, is there any time that you also felt very low to get the diagnosis of bipolar? Yes, we can. And can we get the recording video, please? Yes, that will be given. How to rule out bipolar here? Same. So when you ask about the mood, if the patient says that I'm feeling fantastic now, then you could ask that, is there any time that you also feel very low? If that is the case, then you could give it as a bipolar disorder. It's better to give the differential diagnosis and explain why it is unlikely. Like, why don't you think that this is not schizophrenia? Or why don't you think that this is drug-induced psychosis? How do we describe the mood of a patient in mania? We don't describe it. Patient says. When we ask the patient that how is your mood these days, patient can say, I feel elevated, I feel euphoric, I feel fantastic, I feel amazing. Whatever patient says, that's his mood. So we have to come to correct diagnosis to pass. Ideally, yes, you should get the diagnosis right. All right, thank you guys. Okay, so that's pretty much an idea about these cages. I think you understood a little bit about these cages, how you have to start doing role play, and what are the important things that we look for, and how to at least know that when your time is running out. If you take a lot of history, then most likely you will not get enough time for other two tasks, or even the one task. Here we are explaining the diagnosis and DD to the patient. Definitely. So we would say that most likely from the history, you are having a condition called acute mania. Acute mania is a psychiatric emergency in which patients start to feel very high. They feel euphoric, amazing for a momentary time. And most of the time it persists more than a week. They also start to spend a lot of money. They feel very goal-directed. They have a lot of thoughts going on in their head, and it starts to disrupt their social, occupational, and functional life. It could be also due to other conditions, such as it could be substance abuse disorder, but in your case, you are just using the substance for the last 1 week. You normally don't do binge drinking. It could be schizophrenia, but you don't fulfill the whole criteria to diagnose as schizophrenia. Especially the duration of symptom has to be more than 6 months, but in your case, it is just for 1 week. It could be bipolar disorder, but in your case, you don't feel low at any time, so I still could not make that diagnosis. It depends on what you ask. In the history, you'll have to rule this out. So this is the best way to say the differential diagnosis. If you are running out of time, at least say the name of the differential. That will do. Yes, all the notes are provided in the portal. Okay, that's it for tonight, guys. So I hope you got some idea about how we take classes. I hope you know that what are the role play look like, because we will be talking about role play a lot throughout this course, right? So I hope you at least understand what actually I mean by that. Now, this is the first class of your free 2-week session. There is a lot of classes coming up. And I'm not sure if you know how to look into that. So I will show you our first aid AMC clinical group where you can get all the information that you require. Okay, so just give me a moment. And we'll discuss about the content of the course and everything. And you can also directly ask any questions if you like. So this is our official Facebook group. You can already see that how much doctors has passed in our last October and November. So that's a lot as part of clinical exam. That's a lot of students passing in these months. So if you go to our featured section of this group, you will get all the course details. So you can see the details in here. And we have written in here that This is the first day of our new course. That means you are actually doing our course classes right now. These classes will not be repeated in the course. Okay. So the trial class was taken on 25th February, and I have given the recording also. You can click on this link and you should get it. Free 2 weeks class, the schedule and what topics we are going to discuss, that's also given in here. Remember, the next class will be 12th of March, which will be with Dr. Cynthia, who is going to be your another mentor, very brilliant mentor. She is very well known, like a lot of students passed exam with her files and everything. So what she does is she does random role plays. So she can give you any kind of role play from anywhere, and you have to just do it. And that's how exam is. In exam, you don't know any specific topic. Anything can come in front of your eyes. I know it is a bit difficult initially, but try your best. But again, throughout the course, like once it becomes 1 or 2 months, these classes will become more easier for you. But try to do role play with her. So that will be your next class. The Zoom ID for her classes will be given separately. The Zoom ID that I have added in here, that's not her class Zoom ID. So please be aware of that. And then there are cardiology classes and everything. Now, what this course includes, we do full theory based on cluster-wise approach. Still, you haven't got our cluster-wise approach. That will be the cardiology class, where you will see how our cluster-wise approach work. With the cluster, we try to make 6 to 10 cases in one format. And using that same format, you can finish 6 to 10 cases, which is really good. And it's the smartest way to prepare for AMC clinical. We'll be doing role play of all the important cases. We will do cluster-wise role play like that we have done today. And then also Dr. Cynthia will be doing some random role play with you. That will cover 4 years sample questions, but we mainly focus on the recent one, which is 2024. But all of you will get the videos of all the role play sessions that we have taken in the last 3 years, which covers at least 4 to 5 years role plays. And that's really, really a good amount of questions. And if you can at least finish 1 year of that, there is nothing new that can appear in the exam. Okay? Because it has everything, every topic that can ever come to any kind of exam, that's there. Okay? So there's a huge amount of materials that you will get already. Our physical examination is very well known, and we normally take 1 month just for physical exam because that's a very important part of your preparation. You get also online mini mock exam every 4 to 6 weeks. We do take classes on communication skill and patient-oriented approach. You will get a recording of all the classes that we are taking in the portal, and you will also get prolonged access after the course is finished. The notes in the portal will be until you pass the exam. We also take some classes on the CV making, RMO campaigns, job search, and everything. There is a new class coming up, so we'll give you a post about that. If you're a member of RACGP or ACRAM, you can add our classes and get some CPD. You can also use our course completion certificate. If you don't have 5 months time, so this is a brilliant thing. A lot of time we see that 5 months, many of you might not have it. Many of you are going for exam in April or May. So for those of you who are in that way, you can always join the course and finish our past batch recordings, because we give you full batch recordings and anyone can go through that in their own time. The cost is $899 Australian dollar, which is quite affordable given that this is an Australian registered course, and you will not get any course in Australia which is that much affordable with all of these informations and this much duration. Okay, we don't actually do a business in here. It is about making sure that IMGs like me and every one of you, they know that they can start working in Australia without paying or wasting a lot of money, because you are already You have been paying a lot. You have been wasting a lot of money. Many of you don't have a job. Many of you are in Australia who can't do job in here. So we make sure that this cost is not unbearable for you. Okay? But trust me, the materials, the classes that we take, it's not even like $8.99 is not anything for that part of class, because there's a huge amount of classes that we take, and everything that you need for passing this exam, it is already included in the course. There is nothing else. You don't need to even buy a single book to pass this exam. Okay? So there is 3 days a week class at the moment. So 8:30 to 10:30 p.m. Sydney time. That's it. So if you want to enroll the course, you can either send me an inbox, or you can also just send an email to firstaidamc4536@outlook.com. Okay. And also, if you want to go into our website, you can just write First Aid AMC MCQ. So if you just write firstaidamc.com, this one, then our website will come up, and you can also go through our website. So this is our extensive clinical course, which is starting now. So you can also go through everything that I have discussed from here. Okay. Any questions about the course, guys? Now, the portal can be a little bit tricky for you at the moment. We will take a orientation class after this 2 weeks free session is over, and then we will go through the portal from where to find all the classes. But for now, just remember that in the portal, there is 2 kind of PDF files. One is theory file, and another is all the role play files. Theory files is one that we have taken, like Psychiatry, MSE, that you will find out in the theory file. And in the sample question, you will find all the role play classes. Like this role play session that we have taken today, that will be in the sample question file. How can we get prepared before next class? Now, it's very hard. You can't actually prepare before our classes, because what I recommend is that first know the approach from the class, and then you prepare. You don't need to be pre-prepared. Yes, we'll be giving you a full schedule for 5 months, that how we are going to take the classes. So that will be given to you in 2 weeks' time. Currently, we are more busy with the free classes, and there's a lot of students who we are talking to at the moment. So all these important things which we normally give is after 2 weeks. Recalls are very important. Just like MCQ, clinical also has recalls, and they are important. There is no last day to enroll, but I say that if you want to enroll, you just enroll now, because at the moment it's taking at least 1 week for us to give you access to the portal, because there is a huge amount of workload at the moment. So even our team is working around the clocks, still it is very hard. I hope you understand that, because this course just runs twice in a year. So it's understandable. And that's why I say that don't wait. If you like the classes, then go for enrollment, because it's already taking one week. And if you wait for the last class of the free 2-week session, then we will start the course just immediately. So in that case, you will be in a delay to get all the materials. Okay. The next one will be in August. Can we take a note while talking with the patient? Yes, you can do. Classes are at the moment we are taking Sunday, Wednesday, and Thursday. Yes, so you can definitely add this course as part of your CV, that during this time you have added a course in Australia, and that doesn't give you recency of practice. Recency of practice only comes if you are working as a doctor in anywhere. Not a course, nothing. No course can give you recency of practice. So you can just add this, that you have done a course in Australia to prepare for your AMC clinical. That's okay. And we will discuss about these recencies and everything in one of the class coming soon. Then you should be able to get some basic idea about how to get over this recency. All right, everyone. So let's finish it here tonight. We will again come back on 12th of March. So just in 2 days, we will get another role play session. That role play doesn't have any syllabus. We will do from anywhere. Okay, but it will just for you to understand how our random role play works. But don't get frightened about this class. Okay. Thanks all. Have a good night. Take care.